inflammatory and metabolic disorders. So we'll have some definitions. These are the pathologies. And the first definition I have for you is tessellated. So tessellated is when you have mosaic-like or tile-like or even fish-like scaling on the skin. Okay, we're going to be talking about a pathology later called ichthyosis, where you can see that. All right. The next definition I have for you is acantholysis. So acantholysis or acantholysis, however you want to say it, is basically where keratinocytes, which are generally adherent to one another, for some underlying reason, some process of pathology, they no longer are adherent. Okay, they separate from one another. So there's a loss of the cell-to-cell junctions. There's going to be, with that, loss of integrity of the skin. Okay, which is going to lead to complications in your patient. So, that could lead to, epidermal barrier that's no longer functional. Your patient can be susceptible to injury, through infection, okay, dehydration, electrolyte abnormalities, and so on, okay? With that separation, you're also going to allow for fluid to move in between those cells. And with that, you're going to see specific lesions on the skin, like bullae, okay, or vesicle. And we'll be talking about a couple of different pathologies where you can see acantholysis, okay? All right, so first we're going to be talking about bullous disorders. So the first one we're going to be talking about is pemphigus vulgaris, okay? So pemphigus vulgaris, I'm just going to shut this off so you guys can see. Is a autoimmune reaction that can happen in individuals characteristically between the ages of 40 and 60 years old. Okay, that's going to be important detail when you're comparing this pathology to the next one. Okay, and it's a severe and potentially life-threatening autoimmune reaction. Okay, it's going to affect the skin as well as the mucous membranes. Okay, now this autoimmune reaction is going to happen because there is some sort of trigger, there's some sort of inciting event that's going to spark it. Okay, that could be a variety of different things. That could be infection, that could be malignancy, that could be certain medications, but that triggering event is going to happen, all right? And then your patient is going to develop a rash, okay? So classically, the rash is going to start in the mouth, okay? Like that top left picture, where you're going to see erosions, okay? Now, about a few weeks later or so, you're going to start to see more generalized manifestation of the rash on your patient's body. It's going to be on the trunk, okay, specifically the upper back, but you're also going to see it on your patient's scalp and their face, and then other mucous membranes are going to be involved, all right? So the way that it starts is usually you're going to have erythematous macules that are then going to become vesicles, and those vesicles are then going to become flaccid bullae. Okay, so that's really important detail for this pathology, especially when we compare it to the next. So this is the one where you're going to have flaccid bullae. Just remember that. Okay, now these flaccid bullae are going to be fragile and they're going to break down really easily. And that can lead to sloughing off of the skin, okay, with just lateral pressure, okay, or light action on the skin. What is that called? What sign is that? Nikolsky's sign, exactly. So this can be positive for that. Again, why this is a potentially life-threatening condition for your patient. It should remind you of Stevens-Johnson syndrome in a way, okay? Where you have that, loss of the epidermal barrier. Your patient's going to be susceptible to infections, dehydration, to electrolyte abnormalities. They're going to be really, really sick. They're going to be in the ICU or possibly a burn unit. Okay, so you have to take this condition seriously to be able to recognize it. Okay. Now, it's not just going to affect, again, like the back, the mouth. It can also affect around the eyes, okay, as part of the mucosal areas. It can affect inside the nasal mucosa. Your patient can have epistaxis or like recurrent nosebleeds because of this. When it's affecting inside the mouth, also, your patients can have difficulty drinking and eating, which can lead to dehydration, also malnutrition in these patients. And they're going to have difficulty voiding, okay? So again, it's a pretty serious condition, okay? Now, another thing you might note in your patient is that they're going to have swelling of their digits, okay, where they're going to be erythematous, and there's also going to be some peeling there, okay? All right. Another positive sign for this is going to be Asbo Hansen sign. All right. We've talked about this before, but just as a reminder, this is where you press down on the top of a bulla, and the fluid that's within that bulla is going to extend into the surrounding skin. It's just a way to put it. Okay, so you're going to see that as a positive in this. Okay. So the etiology behind this condition is that it's a hypersensitivity type 2, right, autoimmune reaction, right? This is where your patient is going to have IgG antibodies against desmogleins, okay, which is going to lead to acantholysis, all right? So what are desmogleins? Desmogleins are little structures that you can find on desmosomes. Desmosomes are structures that you can find on the outside of keratinocytes on their surface. It's what allows them, the keratinocytes, to adhere to one another, okay? So when desmogleins are defective, the desmosome doesn't work, okay? The keratinocytes cannot adhere, all right, and they separate. So that's going to lead to this whole inflammatory reaction that you're seeing in your patient's skin, okay? Complement system is also going to be activated as part of this, and, you know, that's why you see what you see, okay? Now, with that separation of the keratinocytes, you're going to have fluid, right, move in between the cells, as I mentioned before, right? So that's going to lead to the flaccid bullae. All right, these are considered intraepidermal bullae, okay? What that means is that the fluid that's accumulating is in the epidermis above the basal layer, okay? That's what causes a flaccid bullae to be a flaccid bullae. All right, I'm going to show you guys a histology slide on the next slide. Hopefully it'll kind of make it make a little bit more sense where this all is happening in the skin. Okay. Does that make sense? The hypersensitivity reaction? Okay. All right. So before we get to the histology slide, which is this slide here, okay, or that picture there rather, I want to talk about how you get the biopsy to obtain that slide. Okay. So what you're going to do with this is you're going to, in terms of your diagnosis for pemphigus vulgaris, you're going to do biopsy time 2, all right, which means you're going to do 2 punch biopsies, okay? So the first biopsy that you're going to do is going to be, out of the way. You guys can see that, but it's going to be essentially a routine histology biopsy, okay? It's called a lesional biopsy. So if you're looking at this image where it says routine histology, that's where you're going to take your first punch biopsy. It's off the edge of the bullet itself, okay? That's going to be sent for routine staining, okay? And we'll talk about what this is going to mean in just a second, all right? In addition to that, you're going to do a second punch biopsy just a few millimeters away, okay, from that lesion. That's where it says BIF, BP, okay, and so on. So that is a perilesional biopsy that you're going to send for direct immunofluorescence. It's going to help confirm your diagnosis. All right. Now you might wonder, okay, why do I need 2 separate biopsies? I know one's going for routine staining, okay, but why do I need to take another one for DIF? Well, I'm going to explain. All right. So you take a second one for DIF, okay, a few millimeters away, because if you were to try and do direct immunofluorescence on a tissue sample that came from one of the lesions exactly, it's going to have too much of a reaction there. All of the immunoreactants, antibodies, and so on are all going to be essentially destroyed. You're going to get a false negative, right? There's just too much chaos happening within that lesion, too much inflammation. Everything is just being utilized, okay? Does that kind of make sense? So if you take it from a few millimeters from that lesion into more normal, less reactive skin, you'll be able to capture those antibodies, okay, and be able to perform direct immunofluorescence. Even though there's an inflammatory reaction happening, it's just not as intense as where the lesion is, okay? So you'll be able to see that, okay? For this particular pathology, when you do direct immunofluorescence using that perilesional biopsy, you're going to see IgG antibodies in the epidermis, okay? That's what's going to confirm, all right? But let's talk about the histology slide, okay? So looking at this slide here, right? So you have this area. This is going to be your stratum corneum, okay, up top. As you work your way down, you're going to get to this like more fuchsia colored line, all right? That's kind of wavy at the bottom. This is the basement membrane, okay, of the epidermis, okay? Just on top of that, you can see that there's a bunch of cells here, this is the basal layer, all right? It's still attached to the basement membrane, okay? These cells, it's called a tombstoning pattern. So that's why there's all these little tombstones kind of superimposed on the image. You're not going to actually see that on the slide, okay? But it's just to let you know of this pattern that's classic for pemphigus vulgaris, okay? Now this white area here, this is where the fluid is accumulating, okay? This is where, this is what's really going to give rise to your flaccid bulla, all right? So the fluid is accumulating above the basal layer, all right? There's not a whole lot of structure, okay, above that fluid. That's why the skin looks kind of wrinkly. All right. I'll show you guys in the next pathology what a tense bulla looks like, okay, in terms of histology. Hopefully it'll make a little bit more sense. We can kind of compare the two, all right? All right. So, that's what you're going to do. You're going to do your 2 biopsies. This is going to carry throughout the lecture. Whenever it's a biopsy time to do, that means we're doing regional and periregional biopsy, okay? All right. So in addition to your biopsies, you could also send your patient for ELISA testing, okay? And that is going to show anti-desmoglein antibodies and anti-epithelial antibodies, okay? Now, I mentioned that there are some medications that play a role in this condition. So penicillamine, captopril, phenobarbital, and cephalosporins sometimes are the inciting trigger for it, all right? This is going to be most commonly seen in individuals who are of Jewish descent or Mediterranean descent. And again, 40 to 60 years old, that's important age bracket for this, okay? This pathology is not itchy, it is painful, as you could imagine with someone's skin just coming right off, right? Okay. So treatment for pemphigus vulgaris. First line is going to be systemic steroids. So that's either going to be oral steroids or IV methylprednisone. Okay, that's going to be post-dose. Of course, you're going to send your patient for wound care, all right? And you're going to give them antibiotics to help stave off any secondary infection, okay, or treat any secondary infection that's there. Another alternative that you can consider is immunosuppressants. So that would be like rituximab or methotrexate or some of the others that I put up here. But this would be for your patient who can't take prednisone, not a candidate for it, all right? Then you consider the immunosuppressives. Or alternatively, if your patient's on prednisone and you want to start to wean them off, you might wean them off to an immunosuppressive, okay? Because you're worried about the side effects of prednisone, okay, in your patient. Now, the reason that we use these systemic steroids and why it matters is because once we started using them to treat these patients, the mortality rate went from 99% down to like 5 to 15%. So patients were doing significantly better. This is why we lean on these medications, okay? All right. Bullous pemphigoid. So bullous pemphigoid is going to be a autoimmune reaction that's going to be most common or I should say most common bullous autoimmune reaction in the elderly, okay? So this is going to be an older age bracket. This is going to be 60 to 80 years old classically, okay? Now, this is not so much a life-threatening condition as it is just a nuisance, okay? It's a type of condition that tends to take a long time to heal and to respond to treatment, and it can last for many years, so it's annoying to your patients, all right? It's more of a chronic process. Now, this autoimmune reaction is going to have some sort of trigger, again, medication, malignancy, infection, a whole wide variety of reasons, but it's going to be triggered, okay? Your patient's going to start to develop lesions, all right? So, classically, what they're going to get are urticarial plaques, okay? So, if you look at these lesions here, ignore the bulla, okay, that's kind of in the center, these plaques, that's what's just going to show up first. Okay, they're going to be intensely itchy, very, very, very itchy condition. Okay, contrasting that to the previous pathology we just talked about. Okay, within a few weeks to a few months, they're going to start to develop bullae, all right, within these urticarial plaques. And with that, you're going to get tense bullae. Okay, they're more solid. All right. They don't easily rupture the way flaccid bullae do. So with this, it's going to have a negative Nikolsky sign. You're not going to see that in this pathology, right? And also a negative Asbow-Hansen sign, okay? Now, it's most common to see these lesions on the axilla. I would say it's very common to see it on the lower legs, okay? Most of the patients that I have who have this, that's where it shows up. Okay, but you can also see it on like the lower abdomen, the groin, all right, and some of the other areas. And then the flexor arms too, okay? So I know that picture is like this, right? It makes you think that this is accept. It's not. It's mostly black. Okay, it's just a good representation of it in that patient. Okay. All right. So the etiology behind this is going to be a hypersensitivity type 2 reaction. It's going to be IgG autoantibodies against hemidesmosomes. Okay, that's going to lead to that acantholysis. Okay. So what's a hemidesmosome? Well, it's a structure that basically allows keratinocytes to adhere or to anchor to the basement membrane. Okay, so they're going to be destroyed, all right, as part of this process. And with that, you're going to see subepidermal blistering or subepidermal bullet, okay? So for this, right, you're going to do your biopsy ×2, lesional and perilesional, right? So let's first talk about your results for perilesional, right? So that's when you send it for direct immunofluorescence, this picture up here, where it looks kind of green, all right? When you send this for direct immunofluorescence, it's going to come back positive for IgG and C3, okay, at the dermal-epidermal junction, which is essentially the basement membrane, right? It's just where the epidermis and dermis meet, okay? And that's that kind of brighter band, all right, that you guys can see kind of right in there. Okay. Now, when it comes to our lesional biopsy that we're sending for routine histology, that's this picture here, all right? So we know that this is subepidermal blistering, right? Fluid accumulation under the basement membrane. That's what you're looking at. All right, you have your stratum corneum at the very top, working your way all the way down to the bottom of that kind of thicker pink area, and then there's white underneath, right? That's where the fluid is. That's the entire epidermis just lifted off of the dermis, okay, with that fluid in between. It's that entire structure that allows for tense bullae to be tense bullae. All right, there's just more around the fluid, so the skin's tighter. Okay, does that kind of make sense? Yeah. Okay. All right. So if it doesn't make sense, that's okay. This is really more so for your knowledge, but I think it's interesting. So I'm gonna tell you guys. All right. In addition to doing your biopsy ×2, you can do ELISA testing, which is going to show you BP antigens that are 230 and 180. These are going to be against those hemidesmosomes. Okay. And when it comes to medications that play a role, so like loop diuretic, okay, metformin, NSAIDs, antibiotics, okay, and again, this is going to be extremely, extremely itchy, okay, can be painful eventually when those bullae break down and get eruptions, all right, but that's not the hallmark of this condition, okay. So these are good things to just kind of keep in mind to differentiate because you know who loves it, right? The pores, okay. So they are probably going to ask you 1 or 2 questions on these 2 pathologies because directly contrast them if you know the details. Easy one. Okay. All right. Treatment. So treatment for bullous pemphigoid, well, it's not as life-threatening, so we have some options and things we can do and try with our patients, which is nice. All right, but you're going to pick your treatment based off of severity. Okay. If it's just localized disease, okay, so there's just maybe a few bullae, maybe on the lower leg, something like that, you could give them topical steroids to apply to those urticarial plaques and then right around that bullae, okay? So high potency usually works well, so like a clobetasol ointment, okay? If it's more severe, then you can consider prednisone, all right? So maybe where like topicals are not practical for your patient to apply, there's too many lesions or it's more widespread, you're going to look towards prednisone, okay, as an option, all right? Or if they're unresponsive to topicals. If not prednisone, immunosuppressants can play a role instead, okay? If you don't want to do that, all right, if your patient is not a candidate for either of these medications, doxycycline can be utilized, which is weird because that's an antibiotic, right? But it has anti-inflammatory effects, and it actually works really well for this, okay? So it's something to consider, okay? If you're worried about, you know, side effects, if you're worried about your patient just not being a candidate for prednisone or immunosuppressants, doxycycline has a much less significant side effect profile. It's more easily tolerated. It's something you can use on, okay? If you wanted to, you could also use doxycycline and a high potency topical steroid in your patients who have like more mild, moderate, presentation. Kind of want to get them under control a little bit faster. All right, of the day instead of two as an adjunct. Right. All right. Now, as I mentioned before, this can spontaneously resolve, but usually it's going to take many years, okay, for treatment to really work, and it becomes more of a chronic process. So you just got to kind of bear with your patient. Okay. All right. Familial benign pemphigus or Hailey-Hailey disease. So this is going to be a genetic related condition. Okay, this is not autoimmune in nature. This is actually a genetic defect, which is going to lead to a particular rash in your patient that is pretty rare. Okay, it's actually not well studied. There's not a whole lot of information on it. We don't really know the exact prevalence of it in the general population. It's oftentimes either not recognized or misdiagnosed. All right, and there is no gold standard treatment for it. There's just some things we can try. Okay, so we'll talk about that. But why does Hailey-Hailey disease happen? Well, there's a genetic defect in a gene called ATP2C1. It codes for magnesium calcium pump. All right. Now, depending on how this shows up in your patient, that pump is either going to be defective or not present at all. Either way, there's not going to be enough calcium, okay, for their cells and for the desmosomes to work properly. So desmosomes in this case are going to be defective. All right. And that's going to lead to ecampolysis. Okay. So, with that, you're going to get a manifestation of a rash. Okay, so the rash typically will occur around the nape of the neck or in the intertriginous areas. And it's going to show up first as little tiny microvesicles. Okay, those little microvesicles are going to be relatively ignored by your patient. They're not going to cause any symptoms. They're probably not even going to know that they're there. All right. Over time, those vesicles are going to break down and you're going to get erosions where those vesicles were. And that's what you have here in this picture, okay? You have all these little erosions that can be painful, all right? Especially in those intertriginous areas where you're going to have friction from your patients moving, all right? Something else that can happen in intertriginous areas, we know we have natural occlusion, right? The areas tend to be more moist, to get, gets a little bit more wet, right, with sweat. You're going to see maceration, okay, this kind of white damp skin that will also then break down, okay? Again, even more painful for your patient. And because of the nature of these areas being warmer, more moist, you're going to see secondary infection, okay? So that could be with like a candida, okay, or Staph aureus, all right? They're going to thrive, okay? It's going to be now painful because of infection. You're going to have pus that's going to come from the area, malodor that can come from the area because that's secondary infection. All right. Cracks and fissures. It's going to be uncomfortable. Okay. All right. I think we pretty much said everything here, other than it's an autosomal dominant inherited disorder. Okay, exacerbating factors. So sweating, right? Friction, that's all going to lead to the feet. Worse, UV lights, that's going to make you sweat more, okay, which is going to exacerbate it. And then again, infection. So we do know, though we don't know the exact prevalence of this condition, that it usually happens after puberty, somewhere between 30 and 40 years old, okay? Your patient's symptoms can be itchy, certainly is going to be painful, and then they can have malodor because of that secondary infection. Diagnosis is going to be clinical if you recognize it, okay, but it's not that prevalent, right? We don't think it is, so it might be hard to know, okay? So for that reason, you're going to do your biopsy ×2. DIF is going to come back negative. Why would it come back negative? It's not autoimmune, yeah, it's going to be a genetic condition, okay? So that in and of itself, when it comes back negative and looking at your patient's clinical presentation is going to help kind of confirm, and back up your suspected diagnosis of Hailey-Hailey disease. All right. And of course, if you think there's secondary infection there, you're going to do your cultures. Okay. So treatment for this, all right, as I said before, there's no gold standard, right? Some things we can do. So general measures, weight loss, loose clothing, all right, trying to kind of keep the areas well ventilated, all right, and avoid friction, okay, avoid heat and sweating, which we know is going to make this worse. Put absorbent pads in the area to help whip away moisture, and also use antibacterial washes like Hibiclens, okay, to help stave off secondary infection. All right. You could give your patient topicals if you think they have, or if your culture has come back positive for, say, bacteria. You give them, a topical antibiotic. All right. Maybe like fluticasone or clindamycin, depending on what's going on. All right. You could give them a topical antifungal to treat that candida that might have also caused secondary infection. All right. Topical steroids. So like a low to mid potency, especially in these intertriginous areas, can also help. All right, it's going to calm down the inflammatory reaction that's going on and hopefully alleviate their lesions a little bit. All right. Oral antibiotics can be utilized like tetracycline for bacterial infection, but also because of their anti-inflammatory effects. Okay, so that's something you can try for your patient. Other options would be like CO2 laser, excision, or dermabrasion. All of these things are going to cause scarring to the area, which actually helps prevent recurrence. So you have to talk to your patient about that. They may not be, or they may be okay with having scarring. All right, and if they are, then maybe just scar the area and get rid of the lesions. It doesn't become a chronic problem for them. Okay, something to talk about. And this is typically going to improve with age. Next, we have dermatitis herpetiformis. So you might look at this and see herpes. Have to do with herpes. No, it actually doesn't. It has nothing to do with herpes at all. All right. It's just called herpetiformis because the lesions that you see are going to be similar to like what you would see with herpes. You're going to get vesicles, typically that are clustered together or in groups. All right. That's going to be your classic lesion. Okay. So what is dermatitis herpetiformis? Well, it's going to be an autoimmune reaction that is closely associated with celiac disease. It's going to be seen in patients who have a gluten sensitivity. All right. So the classic patient is going to be Northern European descent between the ages of 30 and 40 years old, and they're going to have consumed some sort of gluten. So either wheat, barley, or rye. Okay. And they're going to end up getting a rash from it. Okay. And the rash that you see, as I mentioned before, is generally going to be those vesicles. Sometimes you can see papules or urticarial plaques, but usually it's going to be vesicles grouped together. And you're going to find them over the extensor surfaces. So you're going to see it like elbows. Okay, you're going to see it on the knees. But you can also see it on the face, the hairline, okay, the scapular area, and then the buttock. All right. But what's most notable about this condition is that it's going to be bilateral and symmetric. Okay, so if you look at this picture here, this person's knees, where these lesions are, is almost identical. Okay, it's like extremely symmetrical. All right, looking side by side on your patient's extremities. Okay, all right. Now, before the rash shows up, about 8 to 12 hours after they consume gluten, their symptoms are going to be itching. They're going to feel extreme itching in those areas. And then the rash will come on. Okay, once the rash comes on, burning, stinging is going to be, and itching too, more common symptoms. All right. Okay. Now the etiology behind this. So it's going to be IgA, okay, complexing with transglutaminases in the gut. They go out into circulation, they become like a complex, and they deposit in the skin. All right. That's why you're going to see it. Okay. All right. So diagnosis, biopsy times 2, okay, you're gonna look for those IgA antibodies. And for treatment, so gluten-free diet, all right? So avoiding that wheat, barley, rye is going to be very important in terms of like the long-term mainstay for your patient. You just have to avoid those things, okay? To treat the lesions themselves, you could give your patient a high-potency topical steroid to the lesion, that'll work. It might take a little bit longer than the best treatment, which is dapsone, okay, oral dapsone. So this is first line. It works really, really well for these lesions. It'll clear within like a few hours to maybe just a day or two. All right, so it works real fast, which is nice. All right, but dapsone comes with some caveats. It has a lot of drug interactions, okay, and some significant side effects and things we have to be aware of. So you have to make sure that your patient doesn't have G6PD deficiency, okay, or methemoglobinemia, because it could lead to hemolytic anemia. So you have to monitor that and check that in your patient, okay? Really, really important, okay? Dapsone will not help with any enteric manifestations, okay? So like if your patient actually has like celiac disease, okay, that's affecting their gut, Dapsone's not going to help with that, all right? It's only going to help with cutaneous lesions that you see, okay? So for that reason, you're going to refer your patient to the GI, all right, doctor, to have, you know, more of a workup, okay, an evaluation. You'll also refer them to a nutritionist, okay, so they can get their diet under control. And then if for any reason they can't take Dapsone, sulfapyridine is another option. Okay. Epidermolysis bullosa. So this is a condition that there's a lot we could talk about, but I think it's unnecessary for our purposes to get into it on a granular level. So we're just going to talk about this condition very broadly. Okay, and if you guys are interested in reading about all of the details with it, there's a good chapter Fitzpatrick. Okay, where you can get into it. Okay? But I want to make you aware of it anyway. Okay, so epidermolysis bullosa is going to be a complex genetic condition. It's inherited, okay, where patients can have, because it is genetic, variable expressivity of it. You can have it where it's extremely mild, and your patient can go out their whole life without really knowing they have epidermolysis bullosa, okay? Or it can be very severe and potentially life-threatening, okay? And when we see that, it's usually going to be present right at birth, okay? Now, the whole thing with epidermolysis bullosa is that you get a mechanical bullous type of lesion. What that means is that any kind of friction or rubbing or anything on the skin is going to cause development of bullet, all right? So when we see it right at birth, okay, it's like this little big spot here, okay, just gentle handling after birth is going to cause enough friction on the skin for a bullet to show up, okay? Which obviously could be very problematic for a newborn, all right? Especially when those villi break down. It's going to leave them susceptible to infection, okay? You're going to have a compromised skin barrier, all right? So with these newborns, they have to go to the NICU, okay? They're going to need very gentle handling, all right? Their bedding is going to usually be very soft, like sheepskin or foam. They'll have cloth diapers, okay? No adhesives can be applied to the skin of any kind because just that little bit of friction to remove, say, a bandage or paper tape or whatever, it's going to cause a bullet, okay? So very, very gentle, all right? Now, other manifestations of this condition, you can see milia, okay? And I don't have a picture up here, but milia are like these little white cysts in the skin. You can see them with this condition. You can also see them just on their own as like their own thing. All right. They're tiny. They're like 1 to 2 millimeters. They're filled with keratin. Okay. They're usually common on the face. I'll have to put a picture up here next time. But that's something that you guys can see. Okay. And scar. All right. As those villi break down. Okay. All right. Now, with this condition, so I said it's very complex, right? There's 3 different categories of it. All right. There is EB simplex, junctional EB, and then dystrophic EB. All right. With each of these different categories, there's going to be different genes that are involved, different layers of the skin that is involved, and then different antibodies that are going to be involved. All right, which I think is way more than we need to know. Okay. But I want to make you aware that there's at least 3 different classifications for it. And when it comes to diagnosis, you're going to do your biopsy test too. And you're going to do your DIF, right? And whichever antibodies show up, it's going to help correlate which exact category your patient's disease falls into. Okay? That's how you make your diagnosis. Now, we talked about treatment really for newborns. It's going to be similar to those who go into adulthood with this. It's going to be, everything has to be very gentle. Okay? No adhesives or anything like that on the skin. All right, when there's significant flares of it, okay, or when you have that newborn, you have to consider using prednisone or immunosuppressants to get it under control. All right. I've seen this one time as practicing, and my patient didn't come in looking for a diagnosis for it. They actually knew that they had it already, and told me that they were a case study for it, them and their twin. So The only thing that they asked me was when I was doing their full body exam to be careful not to be rough on their skin and don't put any band-aids or anything like that, any kind of adhesive, because they were going to get, full infected. So again, just being mindful of, being very, very gentle on the skin that would be important for this condition. Okay. All right. Metabolic, inherited, and pigmentary disorders. Okay, ichthyosis. So ichthyosis is the word, if you break it down in Greek, ichthys means fish, osis means the condition of. So this is going to be the condition of someone having fish-like skin, all right? With that, you're going to see those tessellated scales, okay, those fish-like scales on their body, okay? Now, there are over 20 different variants of ichthyosis. We're going to talk about the most common four, all right? It's a group of inherited disorders, okay? Basically, the underlying process for this is that your patient's going to have retained keratin, okay? That retained keratin is what's going to lead to these thicker scales, all right? So for all of them that we're talking about, that's the idea, okay? All right. Now, of course, because this is also genetic in nature, have mild presentation, you can have life-threatening presentation. We'll talk about some of that, okay? The classifications we're going to be discussing, so dominant ichthyosis vulgaris. We'll also be talking about X-linked, lamellar, and epidermolytic hyperkeratosis. Okay. All right. So with ichthyosis vulgaris, this is the most common type, okay, of ichthyosis. And in its most mild form, you can have just cirrhosis, which is just dry skin, okay? As it gets worse, okay, if your patient has a worse presentation of it, you're going to get those thicker, bound down, tessellated, fish-like scaling, all right? It's going to cover their body. It's going to spare the flexor surfaces, so like the AC fossa and the axilla won't be affected in this condition, just like what you're seeing here, all right, in this picture. No lesions here. Okay. You can also see hyperlinearity of the palms. So like, look at your own palm, you have natural skin lines, right? They're just going to have more of them and they're going to be more accentuated, okay? And one other thing that you might notice in your patient is that they could have keratosis pilaris. Okay, that's this picture here. So keratosis pilaris is a condition, it's almost like an eczema type of condition. It happens in the context of ichthyosis vulgaris, but it can also just happen on its own. Okay, and it's pretty common in the general population. The lay term for, might hear people refer to it this way, is as chicken skin. Okay, it's not the proper name for it. It's called keratosis pilaris. All right, but that's just because the skin feels a little bit funky. Okay, what you're looking at in this picture is that right around the hair follicles, you have thickening of the skin. Okay, sometimes those that area around the hair follicle can also look a little red, pink color, just like what you're seeing. Okay. Okay. So, with ichthyosis vulgaris, the etiology behind this is going to be that there's a filaggrin gene mutation, okay, that's going to lead to this whole process. All right, so if you guys remember, we talked about filaggrin when we talked about atopic derm, the second question, right? So filaggrin, as a reminder, is a protein that binds keratin together, gives us our strong outer epidermal barrier, okay? When there's decreased filaggrin or filaggrin doesn't work properly, the epidermal barrier is going to be more permeable, okay? Keratinocytes really aren't going to adhere as well to each other. Okay? You're not going to get that strong layer, all right? So with that, you're going to get a lot of transepidermal water loss. The skin is going to dehydrate, all right? Which makes sense why you would see cirrhosis in the condition dry skin, right? But it also gives way to those tessellated scales, okay? What happens, the cells dry out very easily, the skin dries out very easily, and what your body does to compensate for it is it produces more keratinocytes, okay? Because everything's drying out too fast. Put more out there, all right? That's going to give us these really thickened, bound down scales, right? Just keratinocytes, building up on top of each other, okay? And it's just part of the process, okay? You're going to get that extra thick stratum corneum and retained keratin, okay, with extra keratin. Does that kind of make sense? Okay. There's another part to that. So the other part to that is that these individuals are also missing a whole layer of their epidermis, the stratum granulosum. Okay, so another reason why their skin is just drying out so fast. They don't have all the layers that they need. Okay, all right. Now, being that we know how important flagrin is, right, and how it relates to atopic dermatitis, it makes sense that these individuals are also going to have 50% of the time atopic derm. Okay, in addition to this. All right. They're also going to have symptoms of atopy where they're going to have asthma and food-related allergies as well. Okay. Kind of follows suit. Does that make sense? Yeah. All right. So who do we see this in? Those who are usually somewhere between 3 and 12 months of age. On average, it's going to be about 2 months of age where it's going to start to show up first. And it's going to be 1 in every 250 people. Okay. All right. X-linked ichthyosis. So this is going to be seen more classically in males, all right, where they're going to have more brown in color tessellated band down skin, okay? And it's going to affect most areas of their body, including the flexor surfaces, all right? And it's going to be really prominent on the nape of the neck, okay, like right in here, all right? Okay. Now, these individuals, there's not going to be palm or sole involvement, but they are going to have manifestations of this condition outside of their skin. So they're going to have corneal opacities, okay, as part of this process. They're going to have cryptorganism. They're going to have higher rates of testicular cancer and intellectual disability, okay? And the etiology behind this is that there's something called steroid sulfatase. They're going to have a deficiency in this enzyme that's responsible for breaking down something called cholesterol sulfate in the skin. And because of that, the long story of it, cholesterol sulfate doesn't get broken down. You have retained keratinocytes, and you're going to have a thickened stratum corneum. Okay, okay. All right, it's going to lead to hyperkeratosis. Okay, so we see this usually right after birth, on average around 6 months, and on the high end of its prevalence, it's like 1 in every 6,000. Okay. All right. Lamellar ichthyosis. So lamellar ichthyosis is where you're going to have what they call colloidal babies. Okay. These are babies who are going to be born in a yellow membrane. All right. So that's the top 2 images there. Okay. This membrane is going to be problematic for these newborns, and that it's going to be tight. Okay. It's going to restrict their ability to breathe. It's going to restrict their ability to move, and also to feed. Okay, so with that, these little babies are going to be in the NICU. Okay. Now, about 2 to 3 weeks after birth, this membrane is going to shed. Okay. Now, that's going to lead to thermoregulatory issues. Okay, because that was their barrier to the outside world, and now they don't have that anymore. Okay. Again, another reason that they're going to be in the NICU. All right. And it's also going to lead to dehydration and electrolyte abnormalities and other issues, as we know, that come with the compromised skin barrier. All right. Now, when that membrane sheds, all right, about 90% of the time, there's going to be some underlying pathology or process happening on their skin. Okay. 10% of the time, they're going to have normal appearing skin. They're called healing colloidal babies, and that's the end of it. All right, but for the rest, there's going to be some other pathology underneath. And in this case, it's going to be lamellar ichthyosis, okay? So they're going to have really, really bound down scales, okay? They're going to be more brown in color, okay? The scales are going to cover them head to toe, all right? Scales are going to be extremely tight on their body, which is also going to cause issues with breathing, all right, and mobility. The scales can crack, and that could lead to painful fissures, and it can also lead to infection. Okay, they're going to have issues with thermoregulation because all of the sweat glands are destroyed in this process, so they can overheat very, very easily. Okay, where they have hair, especially on their scalp, okay, they can have scarring alopecia because the scales are going to basically destroy them over time. They're also going to have ectropion. Okay, they're going to have that E version of the lower lid, which can compromise their vision. Okay, so it's a pretty significant condition. All right, this doesn't go away. All right. In terms of its etiology, there are many different genes that can cause this. I've listed some of them here for you guys. Okay, and in terms of who gets it, so it's going to be 1 in every 300,000. All right, it's autosomal recessive. All right, then we have epidermolytic hyperkeratosis. So this is also going to be seen pretty much right at birth. These babies are going to basically be born and have red skin. They're going to have erythroderma, is what it's called. Okay. In addition to that, they're going to have vessels and bullae, okay, on their skin, and they're going to have significant healing. Okay. So just like what you're seeing here. Obviously, this is going to lead to thermoregulatory and compromised skin barrier issues. Okay, so they're all going to go to the NICU. All right. Over the course of a few weeks, the skin is going to change, okay? And it's going to become almost more like verrucous-like, like scaling, all right? That's accentuated on the palms and soles too. And it's going to look almost kind of more yellow, all right? With this, the skin is going to peel. You're still going to see vesicles and bullae that are going to pop up on their skin, okay? As the skin starts to peel underneath, you can either have sometimes just a little area of normal appearing skin, or you can see vesicles or bullae that might appear in that area or erosions. Okay. All right. Okay. So because they have a compromised skin barrier, sometimes with secondary infection, they can have an unpleasant odor. Okay. It's described in the textbook as smelling like rancid butter. Okay. So unfortunately, that is something that can also be noted with these patients. The etiology behind this is going to be specifically with these two genes that differentiate for keratin. Okay. And who gets it, we see it 1 in every 300,000. Okay. So when it comes to the diagnosis of any of these ichthyosis-related conditions, it could be clinical, okay, but likely you're going to be sending your patient for genetic testing to test for some of those genes that I've listed out for you guys that goes along with each different presentation, okay? That's going to confirm it. Okay, so newborn, we know they're going to the NICU, okay? For adults, right, when this persists throughout life, you're going to want to recommend emollient, all right? It's going to help moisturize the skin, hopefully keep it a little bit more supple if you can, all right? Treat some of that xerosis and thicker scaling. Keratolytics like urea cream or lactic acid can also be utilized. This is just going to help break down some of those scales and soften them, all right? So something you can also recommend for your patient. There's support groups out there, all right? But your long-term treatment is going to be an oral retinoid. So that's going to be like isotretinoin or acitretin. All right. Now we know that there's a lot of significant side effects that come with these two medications. So there's going to be periods of time where your patient's going to be on these medications, okay? You'll monitor them for side effects and everything, right? Liver function, all of that. And then there's going to be times where they're going to just be off of the medication because their body needs a rest, okay? When they're off that medication, their condition will flare back up, okay? And then you put them back on it, they go on again for a couple months, and it's just going to kind of be like this cycle for them, all right? But when they are on those oral retinoids, it does tend to work really well.
For the adults, like, who live with this, what's their quality of life like?
Especially with like the lamellar ichthyosis, that's particularly hard, right? They have all those like thicker bound down scales. For ichthyosis vulgaris, not so bad if it's just mild and only have xerosis, right? Just dry skin. Just using, you know, emollients and keratolytics would be fine. Sometimes even in moderate presentation. The scales when it's like more mild to moderate, it's not really going to hurt them in the sense that like it's dangerous. So you can just maintain them, okay? But when they have those really good big scales, that's where it shows them. Hard quality like there.
They couldn't like tolerate retinoids or like they were trying to have kids or something. They just have to live.
Yeah. It's really the best treatment for it. Yeah. All right. So next we have melasma. Okay, so melasma is going to be a really common condition that we see all the time. All right, it's a benign condition. All right, and with it, you're going to have a disorder, essentially of hyperpigmentation. Okay, where the body is overproducing melanin. Okay, melanocytes are too active. Now, with that, your patient is going to get these hyperpigmented or brown patches on the face. Okay, sometimes in a mask-like presentation, where it's going to be over the bridge of the nose, onto the mallard cheeks. You can see it over the upper lip, on the chin, and then on the forehead. Okay. It's very well demarcated, and that's pretty much what I'm trying to show you guys here in this picture. Where the area that is affected is, okay, you can see very clearly from like just the regular normal appearance again. Sharply demarcated. Okay. All right. So in terms of its etiology, it's complex. Okay. We do know again that the melanocytes are going to be overactive, producing too much melanin that's either going to be taken up by keratinocytes in the epidermis, or that melanin is just going to be deposited into the dermis. Either way, it's going to lead to the same sort of presentation. Now, there are some risk factors that we know of that contribute to this condition. So, being female, okay. Also having times of high estrogen, so pregnancy or oral contraceptive use. So there's like this hormonal influence to it. Sun exposure. So the sun likes to make dark marks darker, okay? It activates our melanocytes to put out more melanin. So the more sun exposure you have, the more active the melanocytes are, the worse the condition is going to be, okay? Genetic predispositions. So about 60% of the time, individuals who have this will have a first degree relative who also has it. And then just generally having a darker sea complexion to it, okay? Classically, you're going to see this in women between the ages of 20 and 40, and the lesions themselves are not problematic in any way. There's no symptoms. They're just present on the skin, and that's what's going to bring your patient into the office to have it treated, okay? It is a clinical diagnosis. Again, we see it all the time. When you see it on your patient, you're going to recognize and just be able to put them on treatment. Okay, nothing really that you need to do to kind of back that up. All right, in terms of test or anything. Treatment for your patient is going to be sunblock. All right, number one. So again, the sun likes to make dark marks darker, so they need to protect their skin. All right, so those melanocytes aren't being too active. Okay, it's going to be really important. In addition to that, so hydroquinone, okay, it's a 4% bleaching cream that can be applied to the lesions, all right, usually at night for about 6 months, okay, and that's going to help lighten the area. Extremely important you tell your patients to just treat the area, okay, not their whole face, because they're going to end up lightening all of their skin while they're trying to lighten these darker patches. They're going to juice their tail, and the skin tone's not going to eat, okay, so just the affected area only. Okay. Now, one of the caveats to hydroquinone cream is that it can be irritating on the skin, which can lead to post-inflammatory hyperpigmentation, PIH. That's not great in someone who you're trying to alleviate dark marks for, right? So there was another medication called Triluma that someone came up with that has the 4% hydroquinone cream. It also has tretinoin, that topical retinoid, which we also know can be irritating and cause PIH, actually. Okay, but it helps lighten the skin because of the skin turnover. And they said, okay, well, how do we offset these side effects, right? How do we prevent PIH? Well, we add a steroid. Okay, so fluocinolone, okay, acetonide, is like a moderate to low, I would say closer to low steroid that is used in combination with these other two meds, and it helps lighten the skin and it works really well. Okay, all right. Other options. Peels and laser treatments. So these are not covered by insurance and they can be very expensive, okay? But they do work really well. The thing I would tell my patient is don't get this done in the spring or the summertime, okay? Because you're gonna pay a lot of money and then you're gonna go out into the sun, you have to put on your sunscreen and the condition is going to flare and it's gonna come back and all the money that you just spent is gonna be wasted, okay? It's better to do these treatments in like the fall and winter time, okay, where they're not going to be out in the sun as much, and they're going to get more bang for their buck for clearing their skin inflammation. Okay, so that's something that you might want to talk to your patients about. Okay, so don't spend too much money for nothing, right? Okay, vitiligo. So vitiligo is going to be a condition where basically you're going to have destruction of the melanocytes. They are not going to have any melanin. It's going to lead to depigmentation of their skin. Okay. As far as why these melanocytes get destroyed, there's like 3 different theories for it. I would say the most commonly widely accepted one is that there's autoimmune destruction of the melanocyte. Okay. There's also a theory that, like the self-destructive theory, where melanocytes produce toxins as they, or byproducts, as they are producing melanin, and they destroy themselves. And then the other theory is that this is due to the nerves in the skin, and they're putting out chemical mediators that destroy the melanocyte. So a couple of different thoughts processes as to why this happens. Either way, melanocytes are gone. Okay. So with that, you can have vitiligo that is just in one area of your patient's body, just like a small localized spot. You can have it where it's more generalized. Okay. You can get the lip to tip presentation, all right, where it affects the fingertips and then around the mouth. Okay. You can also see it around the eyes. All right. Dorsum of the hands. Okay. So these are some common presentations, and you can see the skin is depigmented, right? White. Okay. What do you guys think is happening here in this patient? Why is their skin red and normal symptom? Sunburn. Exactly, sunburn. So they don't have any melanin that they're producing, right? Because they don't have melanocytes, so they don't have photoprotection. These individuals are going to burn very easily. Sunblock is going to be so important for them. Okay, especially when we're thinking about the prevention of like precancerous and cancerous lesions. Right, their body just cannot photoprotect. Okay, this is going to be susceptible to the Kevner phenomenon. Okay, as another detail to it. All right, any kind of trauma to the area can lead to more vitiligo. All right, and in terms of its description, so it's going to be essentially discrete, depigmented, okay, maculas and patches that you can find, like I said, in various presentations. Okay. There are associated conditions like thyroid disease, pernicious anemia, diabetes, alopecia areata, SLE, RA, there's a bunch. Okay, that kind of trail along with vitiligo. So it's not a bad idea when you have a patient who comes in with it to screen them for these conditions. Okay, just to make sure they don't have it. So that could be, asking questions about it, can also be, if you want to just be safe, sending them back to the PCP or work on these. Okay. So 1% of the world population has this. It's usually going to be present before age 20. All right, and it affects all races. So I just want to mention that because oftentimes we see pictures of individuals who have vitiligo and they have a darker skin complexion. But it's not just those who have a darker skin complexion who are going to be susceptible to this. I think those photos are just more out there only because it's more of a dramatic difference, right, in the skin tone. Those individuals may also be ones who are more likely to go for help as opposed to someone who has a lighter skin tone where maybe it's not as noticeable or only noticeable when they're going, outside and they're tanning themselves. Okay, so just something to be aware of. The lesions themselves are going to be asymptomatic. Okay, no itchy, burning, any kind of symptom associated with them. All right, but it can certainly be destructive to your patient who has it. Okay. Diagnosis for this is oftentimes clinical. You're just going to see it, recognize it, and be able to diagnose them. But if you wanted to, you could do a punch biopsy, okay, into the skin, and you're going to see that there's no melanocytes there, okay? Woods lamp is also useful if you wanted to use it to help kind of confirm your diagnosis. You could have your patient go into that dark room, shine a light on them, and you'll see that it's going to fluoresce like a blue color, okay? Blue white, it's very bright. Okay. Treatment for this. So again, sunblock is going to be really, really important, all right, for protecting the skin. If it's just a small area and it's localized, topical steroids can be utilized, and you'll pick, the potency dependent on the body area, okay, what's safe for those areas. Topical steroids can help with repigmentation, so they're oftentimes used. If you don't want to use a topical steroid, then you can consider one of those calcineurin inhibitors, okay, tacrolimus or primolimus. All right. Cosmetic camouflage can also be recommended to your patient. This is basically makeup that they use to just cover the lesions and help blend with their natural skin tone. There's some really good ones out there. Okay, there's one that's called microskin. Okay, and it basically mimics the skin. It's waterproof. It lasts 3 days. Okay, so it's something that your patient might be interested in utilizing. Okay, just to help camouflage. If it's more widespread disease, topicals are going to be practical again, right? So then you're going to consider light box therapy. So either PUVA or UVB works pretty well, about 85% of the time. Okay. Laser therapy, so this would be like the excimer laser, works well on the face. Okay. And then prednisone can be considered too, all right, just to kind of shut down the inflammatory process that's happening and hopefully stop the progression of the condition that halts it. All right, so something you might consider. Overall, for vitiligo, something I just want to mention is that it's very unique person to person how it's going to affect them. So sometimes you can have an individual who just gets a small area and that's it. Okay. Sometimes you can get an individual who gets a small area and then all of a sudden it's everywhere. Okay. It really depends on the person. But what I would say is that usually what will happen is it kind of comes out a little aggressively and then it lasts for a little while. And then over the course of like a few years, it starts to stabilize out. Okay. So a little bit of a process, but it usually calms down on its own. Okay. Not always the case. Sometimes it's pretty severe, but say on average. Okay. Oculocutaneous albinism. So this is going to be individuals who have an issue with the biosynthesis of melanin. Melanin cannot be produced. Okay. So with that, they're going to have hypopigmented skin. Okay, so very light skin complexion. They're going to have light hair, and they're going to have translucent irises. Okay, so that's why sometimes when you see someone who has the condition, their eyes look red, right? It's because there's actually no pigment to their irises, and when light hits their eye, it reflects back off of the ball of backlighter, okay, in the retina, and shines back out. So that red light reflects that little for people. It's just everywhere, okay? Because there's no pigmentation in the iris. Okay, that obviously can lead to visual disturbances. Okay, in these individuals, they're going to have decreased visual acuity. Okay, and oftentimes they'll also demonstrate nystagmus. So with that being said, you're going to refer them to ophtho. Okay, for management. All right. Okay. So this is going to be classified into many different groups. Okay, I've listed a couple of them here. Again, if you're interested in reading more about this particular condition, there's also a nice chapter in Fitzpatrick's about it too. Okay, but just broad strokes talking about it. So treatment for this, in addition to referring to ophthalmology, is going to be sun protection, right? Because they don't have melanin, so they, again, can't photo protect. So that's going to be seeking shade, staying out of the sun, right? Wearing UV protective clothing, wearing wide brim hats, coming in for routine skin checks, okay, to look for skin cancers. They're going to be more susceptible to it. Okay. Something to note with these individuals when it comes to melanoma, it's not going to be that like brown, black, darkly pigmented melanoma that we're most familiar with, the AD, right? Instead, it's going to be an amelanotic melanoma, meaning that there's no pigment to it. So it's going to look paper red, okay, in color, which can make it hard to identify. Again, white routine skin checks are going to be important for any of those new lesions that might just pop up, okay? You can survey them for that. It can be hard to notice. Acanthosis nigricans. So this is also a very common condition that's relatively benign, all right, but it's highly associated with insulin resistance. So very commonly we see this with diabetes, okay? You can also see it with like PCOS, okay, but I would say diabetes is probably the most common seen. Okay. Now, with acanthosis nigricans, you're going to get a hyperpigmented velvety plaque that is going to be ill-defined, and it's usually going to be over the back of the neck, okay, and in the axilla, okay? It's a classic look for it. Now, with acanthosis nigricans, there's usually a like slow indolent course, okay, with it, meaning it takes months for is to show up for this rash to disappear. Okay, it's not like someone had diabetes and then all of a sudden it's there. It takes a little bit of time. Okay, if your patient had sudden onset of acanthosis nigricans, they're like, this came up in the last month. It's just all of a sudden there, and maybe they also have weight loss and other symptoms. You have to consider malignancy. So lung, breast, and GI are common, okay, for sudden onset of acanthosis nigricans. Okay, overall, pretty rare, but you should be aware of it. It should be on your radar for patients coming in with fast onset weight loss and any of the symptoms related to those cancers. Okay, things to think about. Okay, medications that can play a role. So insulin, oral contraceptives, systemic steroids, and niacin. Okay, some of the common culprits that can also induce this condition. All right. The etiology is going to be dependent on the associated disorder. We see this in about 20% roughly of the U.S. population. And when it comes to patient symptoms, asymptomatic diagnosis is going to be clinical. You're going to see it, you're going to notice it. Okay, no tests really need to be done. However, when you do see it, you're going to want to check your patient out for diagnosis. Okay, so whether that's an A1C or check glucose levels, all right, you're going to do that. Okay, so treatment for this, treat the underlying cause. If their diabetes is under control, this will just go away. Okay, it's not going to linger. All right. If your patient can't get their underlying medical condition under control, it will persist. You can give topical retinoids, ammonium lactate, or urea creams as paralytics to try and soften and lighten the scale. It's going to be disappointing. Okay, they don't work well on their own. Really treating the underlying causes what's going to get this to go away. Okay. And then finally, we have porphyria cutanea tarda. So this is going to be a metabolic disorder where essentially you have too many porphyrins in the skin. Okay, and it's going to lead to a photosensitive reaction. All right, so porphyrins are part of heat synthesis. So when there's a disruption, okay, in that pathway to heme, you're going to get excess porphyrins. All right, so in this case, we're going to have an issue with something called urodecarboxylase. No, uroporphyrinogen decarboxylase. Okay, and that enzyme is going to be disrupted. All right, there's not enough of it. It's going to lead to excess porphyrins in the disrupt the pathway. Okay, all right. So with too many porphyrins, your patient's going to show up. They're going to have hypermelanosis. They're going to have darkening of their skin in some exposed areas. All right, they're going to have hypertrichosis. They're going to have excess hair growth. Okay, they're going to also show up with bullae, okay, or vesicles on normal appearing skin. All right, no rash or anything around it. It's just vesicles that are just going to pop up. All right, in some exposed areas. Very common with the dorsum of the uterus. Okay. Other things you can see, so you can see milia with this as well. Okay. You can see heliotrope around the eyes. All right, occasionally in these patients, and that's pretty much it, really. The history, I've had a patient who came in with this one time, kind of presents the same way. So they came in and they said, every time I have my hands or like out in the sun, they didn't say specifically their hands in the sun, but they said, anytime I'm out in the sun, I notice on my hands I get blisters. And then they said, you know, every time I come in to get it checked by somebody, it's gone. This doesn't last very long. Okay, or they look at it and they say, oh, you came into contact with something, they kind of just send them on their way. So long story short, after a workup, because that's an unusual thing, right? To just all of a sudden get blisters every time you're in the sun, we found that they had porphyria cutanea tarda. All right. So the way that you'll work up your patient, okay, is that you're going to do, well, you can do your biopsies, okay. That's going to be ×2. You'll do a DIF and it's going to show IgG antibodies, okay? But this is not an autoimmune reaction, okay? This is more of like a chemical reaction with the porphyrins and stuff, right? But IgG shows up because the vessels in the skin get damaged. When they get damaged, they get leaky, okay? And antibodies and things in circulation go out to the skin, very commonly IgG. So they kind of just make that correlation, all right? Does that make sense? Sort of, yes, okay. What really helps, so is a 24-hour urine catch looking for elevated porphyrin. Okay, if that comes back positive, which my patient it did, then you can kind of confirm your diagnosis. If you wanted to, I didn't, but if you wanted to, you could have your patient bring in a sample of their urine and you could shine the Woods lamp on it. And it's going to look kind of like an orangey, reddish, or coral kind of color. Okay, that'll also help with your diagnosis. Okay, so who gets it somewhere between ages 30 and 50? I would say my patient was closer to about 50 years old. Okay, he happened to be male, but it affects male and female. Okay, in terms of your patient's symptoms, so those delay vessels can break down, ankle, vision, and risk factors for developing this condition. So liver disease, okay, plays a role. So hemochromatosis, cirrhosis, alcoholism, all of these things affect the liver. The liver is where hormones are processed, okay, and heme screen. So if there's disruption there or damage there, you're going to get an issue, okay, to the exacerbation of this. Estrogen also plays a role, okay, because it affects your liver's ability to basically clear out hormones. Okay, and then smoking. Okay, so treatment for this, treat the underlying cause. If they have liver disease, get that under control. That's going to help. Otherwise, phlebotomy, okay, is going to be the way to go. So your patient's going to go for blood draws to kind of just clear out the hormones, essentially. Okay, get them out of circulation. And that can last for up to 12 months. Okay, so for up to a year, they can be going for this. If your patient cannot have phlebotomy, right, maybe they're anemic or there's some reason that you can't have them going this often for blood work. All right, you could consider low dose hydroxychloroquine. Okay, this is an anti-malarial drug. It has a lot of side effects. You have to be well versed in using this medication. You don't just give it out. Okay, you might send them to a specialist for this, as opposed to just doing it routinely. Okay, but something to think about, and sun avoidance too. Okay, and that's it. Any questions?
This might be stupid. For the PCT, could it be triggered by like UP gel, like getting the nails done, like